Yeah, so this is the first cardiology CCS. Basically, as somebody asked how much time, so it is probably half an hour that you get for the CCS. I think 5 minutes, not even half an hour. The essence of the CCS or to pass the CCS is to be very specific, and at the same time, you should not be missing anything. The aim of this whole course is to make you understand what the examiner wants from the candidate. Though all of us are well read by now, like somebody appearing EDIC 2, I think he is knowledge wise, I think there's not much point telling them what to read or how much they need to learn, but it is more of a presentation problem, especially when you belong to the part like India or Southeast Asia. The problem for the candidates is how you present yourself, how you present the answer, because it is a time-bound exam, and if you can't present your answer the way it should be, then probably even if you know, you'll not be able to pass the exam. That's the primary aim of this course, to make you understand how to present your answer. All right, let's start. So this was the vignette earlier. This was a um, you attended an emergency call in your hospital's acute medical unit during daytime hours, and on arrival, 34-year-old female appears tachypneic with a breath rate of 30, with oxygen saturation of 96% on 15 liters of oxygen. She was tachycardic, blood pressure of 120 by 70. She is febrile with a temperature of 38 degrees centigrade, and she is alert and able to answer questions appropriately, but finds it difficult to complete sentences due to breathing difficulty. She complains of left-sided chest pain that came on abruptly, which is affecting her ability to take deep breaths, and has a swollen left calf that is painful on palpation. Measures to stabilize her are already underway, right? So this will be an initial vignette, the case vignette like that. Um, the aim of this case vignette or expected behavior from the candidate is to mark out few things in here, which you need to understand how to mark the important points here, so that you can you can anticipate what the question will be. So when you look at this clinical scenario, somebody is hypoxic tachypneic, febrile with left-sided chest pain with a swollen calf, and that has all occurred very acutely. So I think with an echo image, they may or may not show it in the beginning, depending on what type of scenario it is. But all this finding with a swollen calf, shortness of breath, tachypnea, a bit of fever and chest pain, it points towards probably a pulmonary embolism. That should ring the bell, right? So now the next question, or usually the question that follows the first vignette, is a very broad question. They will ask you what is your diagnosis or differential diagnosis, and usually it is a broad opening questions. Just give me 1 second. Right. So these are very broad questions to start with. The next one will be, sorry. So what could be the most likely causes of deterioration in this case? So they usually don't ask you the straight away the diagnosis. What is your diagnosis? That will not be the question. So they will ask you something broad. What is your differential diagnosis? Because that sets the tone for the exam, and they can talk around it. So usually you get a differential diagnosis question to start with. But if it is very, very obvious, like somebody with an rhabdomyolysis or somebody with a head injury, they will not ask this question. But in this case, where there is a syndromic presentation means somebody hypoxic, hypoxia is a syndrome, or somebody hypotensive shock, shock is a syndrome, somebody unconscious, that's a syndrome, or somebody bleeding, that's a syndrome. Some sort of syndromic presentation at the beginning will come as a differential diagnosis. But if there is a case which directly every information is given, they will not ask about the differential diagnosis. So make sure that you have a pattern to answer those questions. In this case, there is hypoxia, there is tachypnea, there is fever, there is pain, there is a swollen leg. But the main issue here is the hypoxia. So hypoxia is the question they are looking for a differential diagnosis. Yes, obviously 99% it is pulmonary embolism. But when you look at the answer, if you only stuck with pulmonary embolism, you are stuck. You will get only 1 mark or 2 mark. The rest of the differential you have to talk about, right? If they ask about causes, talk about causes, not a single cause, right? Start with the most relevant one, where it is a pulmonary embolism. So the causes for hypoxia in general or in this patient is respiratory issue, cardiovascular issue, and others that can cause it. Respiratory problem is pulmonary embolism, possible pneumonia, acute exacerbation of asthma, or spontaneous pneumothorax. I'm giving you a list of things, but try to put the relevant name or relevant diagnosis for this patient. In this case, I look for respiratory causes such as pulmonary embolism, possible pneumonia, or any other causes like acute severe asthma, but I need to have a look at the history. What are the other causes that can cause hypoxia in this case? Cardiovascular, such as acute pulmonary edema due to MI or due to aortic dissection, anything but acute pulmonary edema as a cardiovascular cause can cause hypoxia. Other causes like sepsis, secondary to any disorder, like where the patient fits in. In this case, he has a pain on the left side of the chest, which can be a referred pain with a perforated hollow viscous, or it can be a pancreatitis pain also. So the differential here are respiratory causes like pulmonary embolism, pneumonia, possible asthma, needs some more history. I cannot rule out a possibility of acute pulmonary embolism, and other distant causes can be acute pancreatitis or a sepsis due to any other cause. As a secondary manifestation, it can be a lung problem. So in that case, you have to jot down 4 differentials to get full marks. If you are stuck with only pulmonary embolism, you will get 1 or 2 mark. Okay, so start broad always. Now, what is the most probable diagnosis in this case is your acute pulmonary embolism. So you don't jump to the second answer at the first question. You have to keep your differential broad. Okay, that's the first point you need to understand. How do you define hemodynamic instability? Now you know that pulmonary embolism is the thing they are going to talk about. Now, how do you anticipate questions? Pulmonary embolism, they will talk about risk stratification, they will talk about diagnosis or echocardiographic finding, they will talk about treatment modality, they may talk about any trials associated with it, right? And they may talk about recent advances. That same patient can go into a cardiac arrest, the same patient can need ECMO and all those things, hemodynamic support. So this should ring the bell. So these are the things they are going to ask about in this case, okay? So how do we define hemodynamic instability in acute high-risk pulmonary embolism? So you need to know what is called as unstable high-risk PE, okay? So the risk factors or the factors that make the pulmonary embolism hemodynamically unstable high-risk PE are the patient who has pulmonary embolism and had suffered a cardiac arrest, or the patient who has shown obstructive shock, that means the systolic blood pressure less than 90, or vasopressors are required to achieve a blood pressure of 90 despite adequate fluid resuscitation, and there are evidence of end organ perfusion defect, right? Or the patient has persistent hypotension with a systolic blood pressure of less than 90, or systolic blood pressure that has decreased by more than 40 millimeter of mercury, which lasted for 15 minutes and is not caused by new onset arrhythmia, hypovolemia, or sepsis. So this is the complete definition of shock associated with pulmonary embolism, or definition of hemodynamic instability. So patient with cardiac arrest, yes, that's a hemodynamic instability, or the blood pressure that is less than 90 with support of vasopressor after being fully resuscitated. So that's the point that is asking in this question. What do you mean by hemodynamic instability in the context of pulmonary embolism? All right. Now, can I ask any one of you, can I answer what's the context, why they are asking about high risk pulmonary embolism or severe pulmonary embolism? What will be the next question in this thread? Any answer from the group?
Yeah, I think because the treatment depend on the diagnosis. Is it
Correct,
massive or submassive?
correct. Because the treatment varies based on whether it is massive, submassive, high risk features are there or not. All right. Okay. Now that question, like the whole vignette can go in different direction that I already talked about. In this case, what are the other risk factors that increase the risk of venous thromboembolism? So you can talk about risk factors. So this type of question, when they ask about other risk factor, what are the investigations, what are the treatment modalities? When there is a plural type of question, you need to answer multiple. Like you have to give multiple answers to that, right? What are the other risk factor? You just cannot stop saying that, oh, prolonged immobilization or surgery. It cannot be all over the place. You need to have a classification standard, right? The examiner look for how you classify the answer, how organized is your answer. Even if you start that there are some genetic factor, there are some acquired risk factor, and there is some specific ICU related risk factor. Even if you say these three lines, they will say, okay, you know about it. You don't have to utter the all of it. And then genetic factors, we can talk about protein C, protein S deficiency, antithrombin 3 deficiency, or factor 5 latent mutation. Acquired risk factor includes old age, obesity, previous thromboembolism, malignancy, history of vasculitis, pregnancy, patients on hormone replacement therapy or oral contraceptive. But ICU-related risk factors include prolonged immobilization, patients who are mechanically ventilated with sedative drugs, femoral venous catheter placed, or inappropriate doses or lack of thromboprophylaxis. These are the risk factor ICU-related. So you need to classify your answer at the beginning, saying that there are different groups of risk factor, which includes genetic risk factor, which includes acquired risk factor, which includes ICU related risk factor. You can classify anyways. You can say there is modifiable, there is non-modifiable risk factor, whatever you want, but you need to have a structure to answer. You cannot stop at one answer saying that, okay, prolonged immobilization in ICU is a risk factor. Yes, but you get 1 out of 3. You need to have more answers there. Okay. So make sure you listen to the question very patiently what they're asking for, have a framework in your mind and answer it. Now, why I say always framework? Because you have to make the framework beforehand. You cannot discover or invent a framework in front of the examiner. You need to practice these things before going to the exam. That's why I said it is a syndromic approach. You need to have a framework for hypoxia, for unconsciousness, for anuria, for fever, for bleeding. All this has to have a framework in your mind so that you don't miss the differential diagnosis. All right. Now, what is the role of echocardiography? Um, or what does echocardiography has a role in P? So can anyone elaborate on that? How are you going to answer it?
Yes,
And
the echo can identify the maybe the cause of BE if there is any thrombus or valve
yep,
digitation, and can be I mean the effect of BE obstructing the pulmonary vessels like high pressure, dilated ventricle, D shape.
correct. So both diagnosis and management, right? The echocardiography is used in both diagnosis and management of P, right? It is a diagnostic modality where it is a rapid bedside assessment in hemodynamically unstable patient where you cannot do a CTPA or not safe to transfer the patient. Also, coexisting other cardiac abnormalities can be found out, such as valvular abnormalities like a TR. You can measure the pulmonary pressure or the volume status in the patient, but mainly diagnostic modality. But there are some uses in management decisions, like if there is an existence of RV dysfunction on echo criteria, then the patient is considered for thrombolysis, right? So you need to again classify your answer, diagnostic and management uses. Diagnostic is you diagnose whether there is a P or not, if there is any associated abnormalities or not, and also look at the fluid status. Management wise, if there is any RV dysfunction or if there is any high risk feature, then whether the patient needs thrombolysis or not. The decision for thrombolysis can be more robust with the echocardiographic finding. Okay, so you need to talk about it is used as a diagnostic modality, and also it has a role in management or deciding the management. What are the features on 2D echo to suggest diagnosis of PE? Now, anyone has answered this question? You can go through it. Any takers for this?
Sir, if the PA pressures are less than 60 and the acceleration time less than 60 seconds, suggestive of acute PE versus chronic right heart failure. So if these two features are there, then and RARV dilatation with the septal septal flattening. Sir.
Correct. Like you answered most of the thing. So, all right, let's see. There are multiple features, right? You are not expected to talk about all of it. Only two will do. But you need to know if you, I mean, most of us, we know about it also. So first of all, there is decreased RV regional longitudinal function. There is increased RV chamber size. It is found in 25% of the cases. There may be coexisting tricuspid regurgitation. There may be abnormal septal movement that indicate RV pressure overload, something called as a McConnell sign. This is where the RV mid-free wall becomes dyskinetic with relative sparing of the apex and the base. So mid-free wall doesn't move compared to the apex and the base. And there may be a mobile thrombus that you can see on the right side of the heart, either in the ventricle or going into the pulmonary artery. Very rare to see it. There may be a distended non-collapsible infravena cava, which is a representative of a raised right heart pressure. And you told about the 60-60 sign, which describes the simultaneous finding of right ventricular outflow tract acceleration time less than 60, and with a mid systolic notch, and an estimated pulmonary artery systolic pressure of less than 60. So 60-60 sign, McConnell sign, dilated RARV, tricuspid regurgitation, abnormal septal movement, and you may see a mobile thrombus in that. That's a little bit of description of this 60-60 sign. How do you do it? So you put your Doppler through the tricuspid and get the tricuspid regurgitant gradient. How much it is? It should be less than 60 or equal to 60. And through the pulmonary artery, you look for the numbers, pulmonary artery systolic pressure. Sorry, look for the right ventricular outflow tract acceleration time. So that's the 60-60 sign that, but clinically hardly done. You just talk about other visual signs that we talked about. Any two of those will do. The first vignette finishes here. The patient goes into the second vignette, which is the patient begins to deteriorate, which is all expected. That's how the exam goes. She appears drowsy. She is now has a sustained hypotension, 80/40, despite receiving adequate fluid boluses over the last 20 minutes. There is a focused echocardiography that confirms the presence of dilated RV with impaired systolic function with visible mobile thrombus. Her arterial blood gas demonstrates a pH of 7.1 with a PSU2 of 11, bicarb of 11, lactate of 7.4, and potassium of 5.1. The chest radiograph appears normal. Now, because it is a specialty exam, you can get very complicated questions or very complicated data to interpret also. They may show a echo picture with a tricuspid annular plane movement or a TAPSE, and the TAPSE value is like suppose 10 or 1.1 or 1.0 or 0.9, and they will ask you to interpret the TAPSE also, right? So you need to know at least the baseline echocardiographic finding and what are the parameters to explain a right ventricular dysfunction, how much TAPSE is called as moderate dysfunction, how much TAPSE is called as mild dysfunction, what is the normal value of TAPSE. So all those things they can ask you, right? Even if, because it is a very common finding in the ICU, you are expected to know at a consultant level. They may ask you about the numbers, or they may show you the number and ask you to interpret the image. Okay, so don't think that, oh yeah, only RA RV dilatation will be on the echo. They may show you the Doppler finding and ask you to interpret it, because it is a common expectation that a ICU specialist knows about it, right? So I will recommend to look at the echocardiographic finding of a right heart dysfunction or pulmonary embolism um, um, before your exam, or make sure that you are acquainted with it, right? Okay, we have seen this multiple times, so I'm not showing that. There is a mobile thrombus on the right side of the heart. The RV looks dilated, though this is a foreshortened image, but definitely the LV is less in size compared to the RV, and there is a mobile thrombus in the RV cavity. All right. So what are your immediate concerns after shifting to the ICU? Very generic question. So you need to talk about the patient is hypoxic, may need intubation and mechanical ventilation. He is hemodynamically not stable. His blood pressure is low. So I'll continue fluid resuscitation or um, dynamic parameters of hemodynamic management. I'll look for um, pulse pressure variation or straight leg raise or echo to see what is the fluid status and continue fluid resuscitating. At the same time, I'll titrate my vasopressor. I will put some advanced cardiac monitoring and plan for definitive management. So this is a two-part question. You need to talk about general management, number 1 to number 4, but at the same time, you need to talk about specific management, right? Because only general management will not treat this patient. This is all supporting. You need to talk about specific also. So for a pulmonary embolism, the specific management includes, first of all, risk stratification, then assess for suitability for thrombolysis, or you need to do a catheter-directed therapy, which includes thrombectomy or thrombolysis or catheter-directed thrombolysis, depending on the risk factors, the situation, and the expertise available. My point is, when they ask you about immediate concern or what is the immediate management, you don't stop at one. You have to talk about airway, breathing, circulation, monitoring, and a definitive plan. Okay. If you leave this definitive plan, then you'll get half mark, and the examiner may not go to the next question till you see this or say this. Okay. Now, again, the question can go various ways. They can show you an X-ray, they can show you an echo, they can show you a CT scan, or just an ECG. Based on what is the we need. It's very hard to replicate what they're going to ask you. There are many things can be asked in that scenario. But in this case, what we thought is talk about the ECG, a little bit of ECG, what you see in pulmonary embolism. So, which ECG abnormalities are associated with poor prognosis in patients with diagnosed PE, right? Basically, more or less, any ECG abnormality that you see in PE has a poor prognosis. That's the bottom line of it. Most of the patient will have a tachycardia. There will be new or complete right bundle branch block. The patient may have new onset arrhythmias, particularly atrial fibrillation. There may be ST elevation in the AVR, which is a little bit of unusual finding. If we see this, then it rings the bell. Around 20% of patients may show you S1Q3T3 pattern, which is not diagnostic, not prognostic, but it is seen in 20% of the cases. There may be anterior ST segment changes in T wave inversion because that corresponds to the part of the heart, right? So any of the ECG abnormalities can be there, and which represents a poor prognosis also. What is the rationale of ordering a chest X-ray in pulmonary embolism? All right, I will leave this question to you guys to answer, one of you, if you can attempt or you want to attempt.
To rule out other differential diagnosis of pulmonary embolism, like a pneumonia or a pleural effusion or an aortic dissection. To rule out other differentials, we need to order a chest radiograph.
Yep, that's correct. But aortic dissection, can you rule out with this? Very hard to rule out a dissection with a chest X-ray. You talk about something which you are sure about, okay? The first answer was correct. To rule out any other pathology, which includes pneumonia or lobar pneumonia, fluid overload, any other pathology such as pleural effusion, pneumothorax, all those things that can mimic the pulmonary embolism. That is the reason why we do a chest radiograph. That is correct. To investigate other causes of this presentation, mostly the X-rays are normal, okay, if it is only a pulmonary embolism. Now the third vignette, the patient goes into the third vignette. So following, and as I said, it can go anywhere. The patient may have a cardiac arrest and gone into ECMO. The patient may have a cardiac arrest and there will be prolonged CPR and the post cardiac arrest prognosis pathway. It can go anywhere, right? Um, in this course, we talk about systems, like we talk about cardiovascular, nephrology, neurology, all those system wise. But in the exam, everything mixes together, right? That's how the things are in reality also in ICU. Never a patient comes with a straightforward diagnosis. A patient with pulmonary embolism will have a renal failure for sure, or mostly. So you need to know about renal failure. You need to know about pulmonary embolism also. So that's how the cases will be. This course is built up like that. You learn about a system, approach a patient in a single system, and towards the end where we do the whole syllabus mock test, then we mix and match. Then you develop the idea to look at in different system rather than just looking at the heart, right? Now, following the uneventful intubation, the patient is now intubated. She is placed on mechanical ventilation with aim of avoiding high plateau pressure. The central line is placed and the noradrenaline infusion is rapidly started, and it rapidly rises to 0.6 microgram per kg per minute. After 30 minutes following intubation, her blood pressure still remains at 85/40, saturating 90 to 92% on a FiO2 to 100%, and she is now more tachycardic. On clinical examination and bedside lung ultrasound, there is no evidence of pneumothorax. Urgent CTPA was done, which revealed a P with the evidence of right ventricular dysfunction. Okay. Now, what do you anticipate? What the question will be? They have shown you a CT scan. There is a saddle embolus, and there is a RV dilated RV. What will be the next question in this case? Obviously, it will talk about what are your main treatment priorities at this point. Okay. Right. Because this case is evolving as a P and the patient is still, we are still talking about P and management of P. The previous vignette we talked about general supportive care and then specific treatment. When they are in this vignette asking about what are your management priorities, you have to be very specific here because you've talked about all the vague things earlier, right? In this case, what is your main treatment priority is to thrombolize the patient because he has ongoing shock in spite of high NORAD, requirement. There is end organ dysfunction. He is still hypoxic. So there is no way out. He needs a procedure to decrease the clot burden, which can be either thrombolysis or embolectomy, right? So thrombolysis, the greatest benefit is seen when thrombolysis is given for 48 hours. This is just for explanation I'm talking about. You don't need to order about it. And embolectomy in patients who have clear contraindications to thrombolysis, the emboli can be removed surgically or using a catheter. Now, we talked about thrombolysis and embolectomy. Most probably, sorry, someone needs to mute the microphone, please. All right. So the next question will be about thrombolysis, exploring more about thrombolysis or more about thrombectomy, right? So describe the absolute and relative contraindication of thrombolysis. So whenever there is a thrombolysis question, this is a surrogate question to it, whether it is a MI getting thrombolized, whether it is a stroke getting thrombolized, whether it is a pulmonary embolism getting thrombolized. So you will expect 90% chances that you will expect this question, right? Again, what are the absolute and relative contraindication? You need to talk about absolute first and the relative next, okay? Absolute is a complete list. There is a relative contraindication. There is a complete list. I don't need to go in detail about it. You can read about it in any of the journals or any of the websites, but you need to know at least three each of it, right? What is absolute? What is relative contraindication? And this is important because it covers three pathologies: in stroke, in MI, and in pulmonary embolism. Vignette 4, the decision is made to administer altiplase. She has urgently received initial 10 milligram bolus over 1 to 2 minutes, followed by 90 milligram bolus, 90 milligram over 2 hours. She was continued on high dose NORAD and adrenaline infusion. Patient was oliguric on admission, which progressed to anuria. Repeat blood gas revealed worsening metabolic acidosis with rising lactates. Sodium bicarbonate infusion was started. She was started on CVVHD. Continued cardiogenic shock and lack of lactate clearance and lack of hemodynamic improvement and onset of multi-organ dysfunction prompted to initiate a peripheral VA ECMO. As I said, it can fan into any scenario like a cardiac arrest or a VA ECMO or any other thing. Okay, in this case ECMO. Now, if they're asking about ECMO, they will start with a question which is very generic to ECMO, like very general question, and then they gradually make it difficult for you, right? So what are the indication of VA ECMO in general, right? Not in this patient, they're asking about in general. Again, what are the indications? It's not a 1 mark question. You have to talk about few of them, okay? Now you need to have a classification format in your brain to answer it quickly in the exam. So what are the indication? Cardiogenic shock, anything related to heart, like due to acute coronary syndrome or malignant arrhythmias, myocarditis, or pulmonary embolism. Patients with cardiac trauma, patients who have undergone a cardiotomy because of CP bypass or transplant graft failure, or it can be used as a bridging therapy for transplant or ventricular assisted devices. The other uses can be in drug overdoses where you want to buy time and patients with anaphylaxis. But I haven't seen one with anaphylaxis being done in my setup. But you need to have a clear idea how are you going to talk about the indications for ECMO, cardiogenic shock due to XYZ, cardiac trauma, post-cardiotomy, and a bridging therapy. There are 4 more major indications and drug overdose. Sorry, 5 major indications for that. What are the unique complications of VA ECMO, right? Anyone want to try this question?
Because we cannulate the artery in VA ECMO, so the ischemia is more common. The second thing, because the VA ECMO, we cannulate the arterial system also, so we have 2 circulation. The circulation coming from the heart and the circulation coming from the catheter. So we have what they call it differential oxygenation.
All
I
right.
think this is what I remember.
Correct, almost. So I have given limb ischemia. This is the major complication that you gave. Usually, you can have LV distension and you can have differential hypoxia. These are 3 things you can have, okay? But for this answer sake, I have given 2. But the examiner expects you to talk about limb ischemia. LV distension or differential hypoxia are fancy complications that do happen. But the most common is a limb ischemia that you should not forget about. Okay, bleeding, that's another complication that you should not forget about. Okay, common things you need to ask about commonly. What is called as an LV distension? So ECMO has a multiple question thread. They can ask about anticoagulation in ECMO. They can ask about oxygenation failure. They can ask about what are the complications that can happen in ECMO. They can ask about contraindications for ECMO, or they can change the scenario day by day. First day this happens, second day this happens. So multiple things that can be asked. In this case, I'm asking about the complication. What do you mean by LV distension? Can anybody answer this?
So the returning blood to the arterial circulation brought a pressure over the left ventricle and increases the left ventricular afterload. So that leads to distension.
Yeah, that's correct. So as VA ECMO can increase LV afterload, and a low LV ejection fraction can lead to LV dysfunction. Okay. Because of the afterload, the heart cannot push the blood into the arterial system so that it passively gets distended, which can cause stasis of the blood, which can cause thrombus in the heart, left arterial system, which can cause further back pressure into the lung, causing pulmonary hemorrhage, high PA pressures, and all those things. So you need to read about the complications of ECMO, VA ECMO, and VV ECMO separately, and you need to know more about these complications and how do you treat it. Because you cannot pass this exam saying that I in my setup don't do ECMO and I don't know. That's not an excuse. As a specialist appearing for a European exam, you whether irrespective of whether you do ECMO or not, you are expected to know about it. So make sure that you read about it in and out, complications of ECMO, how to manage it. Right? There are articles, useful articles that we have provided in the study material. Refer to them and make sure that you keep notes of them. All right. Now, how do you detect it? This is an important question. So frequent echocardiographic, depending on which center you are working, whether you are eco-friendly unit or not. So frequent echocardiography can detect, which shows a minimal opening of the aortic valve, nothing flowing forward. So that's why the LV gets distended. Even the daily chest X-ray can be helpful because you can see the enlarged heart border with signs of pulmonary edema because of the back pressure. If the patient has a pulmonary artery catheter, which is usually not put in, but in your setup, if it is there, then you can have a high wedge pressure and a PA pressure, and also monitoring with other hemodynamic parameters, right? So these are the things you look for to detect LV distension. Again, you can classify your answer like direct objective things such as echocardiographic finding and X-ray, increasing size of the heart border. Indirect signs, which includes a high wedge pressure or a PA pressures. How do you manage LV distension? Anybody volunteer?
By inserting an LV vent, LV
Yep.
distension can be managed.
Anything else?
Yes, by weaning the flow of the ECMO by also anatropes.
Yes.
And then lastly, surgical.
All right. Let's see. You need to talk about at least two. All of you are correct, but you need to talk about different options, right? That's why always remember things in a sequential manner. How do you do it? Okay. Rather than talking about the most fancy thing in the beginning, if you face this patient practically, how do you do it? Remember that way, right? So the first principle is to reduce afterload with vasodilatory agents if the map is adequate. Usually not the first, but some centers use the vasodilatory sotalol or some sort of beta blocker if the map is adequate. You can increase the inotropy by increasing or dialing up the inotrope requirement. You can diurese the patient or ultrafiltrate the patient with a CVVH, or you can put an IABP, right? If all these things are failing, then you can think of a catheter-based pump or an impeller type of device, or creation of atrial septoplasty or left ventricular decompression measures such as surgical LV vent, right? So you need to talk about non-surgical approach and then surgical approach. Okay, that's how usually you do in the clinical practice. Start some vasodilator if the patient is tolerating that, or if you think inotropy will help to forward flow, increase the forward flow. In that case, start some inotrope, diurese the patient, ultrafiltrate the patient, put an IABP if required. If everything failed, then talk about surgery. Surgery are different types. You can put a LV vent, you can put a septostomy, or you can have catheter-based pump such as Impera can be used, right? So at least two options needs to be done or talked about in this answer. We need 5. The patient vasopressor requirement started to downtrend and the patient started improving 48 hours post commencing the VA ECMO. Day 3 post commencement of ECMO, the saturation on the right arm dropped to 88% and arterial blood gas from the right radial artery, everything is right, okay? Artery confirmed a PaO2 of 45 millimeter mercury. The saturation from the other extremities were normal. Chest X-ray demonstrated a right upper lobe atelectasis. Echocardiogram showed improved LV function with well opening of the aortic valve. Now, as somebody has told about this already, this complication already, but suppose this comes as a single question that there is a scenario and you have these findings, no prelude to it, no previous history to it. In this case, the things that you look for is well opening aortic valve. If the aortic valve is opening and the patient is on ECMO, there is something wrong, right? That means your heart is improving. You may not need the ECMO further. You try to wean off the ECMO and take it out. That's the problem here, because the patient is having what sort of problem? Anybody can reiterate that? Harlequin syndrome or differential hypoxia. Okay. So saturation of the upper part of the body is lower than the lower part of the body. This is due to the flow competition between the aorta and the recovering, between the ECMO and the recovering heart. Okay. A little bit discussion about it. So initially there is no cardiac function or zero cardiac function. Everything is red because your ECMO flow is going into the aorta and from there to everywhere into the brain. Right and left are well perfused. Now cardiac function is very low. You still have blood going in there, a little bit of mixing, but it is more proximal to the heart, and the right and left side of the brain is getting adequately oxygenated blood. But when the cardiac function starts to improve, this mixing point starts more distally towards the ECMO cannula, because you are pumping blood from the heart here, and also there is a blood coming from the aorta through the ECMO. And the mixing point, if it crosses your right side of the circulation, then you will be hypoxic on the right side. So that's why we always maintain a radial arterial line on the right side to compare it with the other side or ECMO saturation. So the right side saturation will be less in case of mixing point going more towards the ECMO cannula or distal. That is called as Harlequin syndrome. How will you troubleshoot this condition? Any idea? Anyone wants to volunteer? No one?
Wean the patient from the ECMO, sir.
Yes, one. That's one of them. Always have few others ready, okay? Otherwise it will be half mark. So first thing first, what will you do? The patient is hypoxic, increase the PEEP, increase the FiO2, optimize the ventilator setting, right? Now the second, if you still need the ECMO support, think of central cannulation or going from the top, the cannula, return cannula going from the top, so that you bypass that hypoxic area and you put the blood more proximal to the heart, right? Or you think the patient has adequate recovery of the heart, then you think of decannulating this. Or you can change the configuration to a VAV in case of, or instead of VA, you can change it to a VAV configuration. As an alternate, you can put an impella also in this case. But usually, things that we do usually increase the PEEP, FiO2, and look for taking the patient off the ECMO usually help. Very rarely you put a VAV or you need something like an impeller to boost the cardiac output, right?
Sir, in the previous question, if actually the Harlequin syndrome occurs because of when you're having a recovering heart. So in such scenarios, when we how will impeller and other kind of devices
No,
actually
as an
help?
alternate, not. You have to take the patient out of the ECMO and put impella on as an alternate, not an additional. Take the ECMO out. If the patient still needs, you can put an impella on. This will supplement the LV, and there is no ECMO in this patient now.
You will elaborate
Okay, sir.
more on VAV ECMO. Yes.
Sorry, didn't get that.
Would you elaborate more on VAV ECMO?
So where is the access and where is the return cannula in VA and VAV? So in this case, what you do is you put more oxygenated blood into the venous cannula, an additional venous cannula, so that the mixing will increase the PO2. So you have a cannula, you have a V cannula in the VA ECMO. You add another venous cannula where you are putting more oxygenated blood.
Thank you. Yes, clear.
So that the overall PO2 of the blood increases and the brain gets some more oxygenated blood. Okay. All right. What are the major trials on VA ECMO on CPR? So there are multiple trials that have come recently also, but I have chosen two to write: ARREST trial and CHEER 2 trial. Usually they are not first about any specific trials, which are not very known, but if they are talking about ECMO, you need to know about the Caesar trial. You need to know about the trial in eCPR, the CHEER trial and ARREST trial, at least the outcome of those, right? So they may be asking about it. It can go anywhere, like it can go to a bleeding condition where they can show you the coagulation studies and find out how do you correct the coagulation or how do you correct the coagulopathy. The patient can have a bleed in the brain and then ask, well, this is a complication, how do you prognosticate the patient? It can go anywhere after the ECMO, okay? In this case, we'll see what is going on. So on stopping the sedation, the patient was not waking up appropriately and had upper motor neuron sign. The CT brain was done, which showed this. Okay. Now, what are the risk factors for intracranial hemorrhage in ECMO patients? This is a very vague question. Nobody is expected to remember this, but you can talk about few general things, right? Few of the questions will be a general sense. So use of anticoagulation, thrombocytopenia, patients with a high severity score, patients who have a high PaO2 in the ECMO initiation. Because of the variation in the ECMO, there may be blood flow variation causing bleeding into the brain, and long duration of ECMO. So these are the very generalized question. You don't have to remember them, but coagulopathy, thrombocytopenia, use of high dose of heparin, and high severity score at the beginning are the risk factor for having intracranial hemorrhage. But these are all a non-randomized trial where they look at patients on ECMO who had intracranial hemorrhage and did some analysis like a multivariate analysis, find out the risk factors for intracranial hemorrhage. What is the mechanism of intracranial hemorrhage in ECMO patient? So first of all, low cerebral blood flow. This is the proposed mechanism. Hypoxia can cause that. Acidosis can cause that. Reperfusion injury after the ECMO initiation, that can cause it. Rapid shifts of any gases like PCO2 or PO2 that can lead to vasoconstriction or acute vasodilatation, that can cause it. Or if the patient has pre-existing coagulopathy or is being on antiplatelet or has thrombocytopenia. So these are the mechanisms that can cause intracranial bleed. It is not an uncommon phenomena. 5 to 10% patient can have it during the ECMO or towards the tail end of the ECMO run, they can have it. Unit 7, day 5, patient was decannulated successfully on sedation hold for 48 hours. His GCS was E1, VT, and M2. Kidney functions have improved. Urea and creatinine liver function tests are within normal limit, making 30 to 50 ml of urine. Last fentanyl dose was 48 hours ago and has been off propofol since. So 2 days observation. Bedside nurse reported the patient has tonic roving movement of the eye. Electrolytes are normal, sodium is normal, potassium is okay, everything else is normal. Blood gas values are within normal limit. She has no neck stiffness and has been afebrile for 48 hours. So everything looks normal, but the GCS is low and she has some roving tonic movement of the eye. What is the suspicion? What's happening here? Any takers?
New onset convulsions.
What sort of convulsion?
Maybe expanding of the bleeding. This is one. Or
Yes, that's a cause. Yeah, that's a cause. Yep. But what sort of convulsion you think? He's not fitting, just the roving eye movement, maybe there.
Non-convulsive status.
Yeah, that's what it is. So that's what is happening. All right. What is your differential diagnosis and what is your provisional diagnosis for this encephalopathy? So you need to talk about few of the probables and then find out what is the main cause or what may be the most probable cause. Can anyone give a go?
Differential diagnosis for the altered sensorium could be any new onset bleed, any new onset stroke, convulsions, then any electrolyte abnormality like hyponatremia or hypernatremia, then new onset sepsis, uh, or any liver dysfunction, which could with the raised ammonia, or uremia secondary to any other cause. This could be the differential diagnosis for the encephalopathy.
Yeah. And your 1-point diagnosis is probably non-convulsive seizure. So start with the most probable one, non-convulsive seizure, but it may be a progression of the bleed or any other intercranial event such as new ischemic stroke, subarachnoid hemorrhage, or any other reasonable answer can do, right? How will you further evaluate this patient? So what will you do? Just a practical question. If you face this patient in this situation, what will you do?
Repeat CT scan, brain, and
Yep.
and 24-hour electroencephalogram.
Yep. But the
Yeah,
major
so
thing, terminate the seizure.
Check for the
Yeah.
coagulation to rule out coagulopathy.
Yeah, how do you terminate the seizure if you are thinking it is a non-convulsive seizure? In this case, will you give some empiric anti-epileptic to start with till you have a definitive diagnosis? Yes or no?
Yes,
Yes, sir.
Yes.
yes,
The
of
first
course.
thing you
Yeah.
will do, isn't it? That's the first thing you will do. Then evaluate. Go for a CT to see if there is an expansion of the bleed or not. So what you do usually, just talk about it, right? So you ask for EEG, rule out any potential drug causing the encephalopathy, definitely CT brain. Repeat electrolytes, the sodium level 146, whether it has jumped up further or not, and rule out any other mechanical factors, or sorry, metabolic factors such as high ammonia in the context if they are on the valve. These are all general thing. If there is a history, you talk about it and rule out any drug causes. Okay, that's the evaluation. Then how will you treat this patient? So empiric anti-epileptic, that is midazolam, lorazepam, whatever you practice in your practice, you talk about it. My practice is to give incremental dose till the seizure stops, or the roving eye or tonic eye movement, or the hippo stops, and I will ask for a continuous EEG to see if there are any epileptiform focus. Now they can ask you about EEG here. What is the role of EEG? That's a diagnostic and a therapeutic again. Diagnostic is to see if there is ongoing epileptiform activity which ticks for a non-convulsive seizure. The therapeutic part of it is you aim for a burst suppression. If it is a non-convulsive seizure, you aim for a or a status epilepticus, non-convulsive type, then you aim for a burst suppression for a prolonged period of time, like 24 hours or 72 hours, based on what the neurologist advised, right? You load the patient with levetiracetam if it is your practice. But if the patient still has ongoing seizures, then add phenytoin as second drug or third drug. Okay. Target the treatment to burst suppression for EEG for a particular defined time frame. You use the monitoring as a continuous EEG monitoring if your facility allows it. Now, how does non-convulsive seizure affect morbidity or length of stay and mortality compared to convulsive status epilepticus, which is bad?
Non-convulsive status epilepticus.
Okay.
It's really,
How
it's
come
really
like
affecting the outcome, the neuro outcome and mortality, because it is subclinical, usually missed
Yep.
in diagnosis.
Mhm.
And with ongoing non-convulsive seizure, there is definitely brain damage and edema formation,
All right. Okay.
which can
So
worsen the outcome up, which can worsening the neuro outcome up to brain death, herniation, and
yes,
increasing
yes.
the
It's a
mortality
poor
as well.
prognostic
And
sign.
yeah, definitely.
Yeah, it's a poor prognostic sign, and both length of stay and mortality is worse if the patient has non-convulsive seizure compared to a convulsive status epilepticus, right? All right, that finishes the first CCS. We'll go ahead with the second, if you guys are okay with it. Right, this is a 52-year-old male is admitted to ER with a 3-hour history of chest pain and shortness of breath. Type 2 diabetic, hypertensive, regular treatment, GCS of 15. Blood pressure is fine, temperature is fine, has a, blood pressure is low, heart rate is high. There is a peripheral cap refill which is sluggish at 5 seconds. Hypoxic, 91% on 10 liters of oxygen, tachypneic, and chest auscultation reveal fine crackles bilaterally. ECG and X-ray done in ER is as shown. All right. So, what is your differential? That is the first question, I guess. Let's see. Oh, yeah, sorry. What is your provisional? So, diagnosis. In this case, they asked about the provisional diagnosis, and there are multiple abnormality that you have to talk about. There are multiple coexisting abnormality, which is the patient has interval MI in the ECG. He has cardiogenic shock because of the low blood pressure and has acute cardiogenic pulmonary edema based on the desaturation and the chest X-ray findings. So he has at least 3 findings there. That's why they talked about what is the provisional diagnosis, what the patient has at this moment, rather than a differential diagnosis. But it can be asked anyways, okay? I don't know why the animation is doing that, but that's all right. So now we'll go in the pathway of MI or acute myocardial infarction and talk about that. Our questions are on based on that. So what are the diagnostic criteria of acute myocardial infarction? So clinical criteria, ECG criteria, and cardiac biomarkers. There are 3 things that has to be there. The patient has typical chest pain with suggestive ECG changes, and there are raised cardiac biomarkers. You have to talk about all these 3 points. If you miss one, you lose 1 mark, okay? Or you may get 0 also, depending on what the answer grid is. They may, it's because this is a bread and butter question. You cannot go wrong with this, okay? If you even miss 1, they may give you a 0, like the EDIC part 1 exam. So if you get 2 wrong, the whole answer sheet will be 0. So in that way, if you miss 1 important finding, then the answer will be 0, even if you talk about 2 correct options. Now, definition of STEMI, just going a little bit in detail. You need to know in and out of that. STEMI, ECG, which territory, which artery involved, what are the ECG finding, you need to know in and out of it, because the CBS, there will be a chunk of question on ECG, identification, and the sub question to that will be which artery is blocked, which territory is blocked, right? So definition of STEMI, the new ST elevation at the J point in 2 contiguous lead, more than 0.1 millivolt in all leads other than V2 and V3. If it is V2 and V3, we require more than 0.2 millivolt elevation in man and more than 0.25 in who are older than 40 is more than 0.2, and who are younger than 40 more than 0.25. In women, there is a less target, that is a 0.15. Other conditions which are treated as STEMI are still there. So they include LBBB, whether new or presumed to be new, and isolated posterior MI. The presence of reciprocal ST depressions help to confirm the diagnosis. That's the definition or ECG criteria of the MI. The criteria for acute myocardial infarction, that is 1, 2, and type 3 MI. So clinical evidence of acute MI with increased troponin, as I told, and one of the following. So clinical criteria, troponin, and one of the following, which includes new ischemic ECG changes, development of pathological Q waves, imaging evidence, echo show multi-territory, what do you call, dyskinesia or hypokinesia, and identification of coronary thrombus on angiography or autopsy. These are the things that should be there. You need to know this definition, right? We talked about that earlier. Again, an important table to remember. So if you have ECG changes at particular leads, then you suspect the ischemia to be involving particular arterial territory. This you need to know and by heart. So this is all freely available in the internet. Deranged physiology, or if you go to the Life in the First Lane, they have a good diagram. I would suggest just print out this diagram and put it on your wall so that every day you look at it and revise it, so that you doesn't lose a minute in the exam evaluating it. How will you classify MIs? Types of MI. So there are 5 types, 1, 2, 3, 4, and 5. One is a primary ischemic. Second is increase of oxygen demand. We call it as type 2 MI. And there is an imbalance between demand and supply. Type 3 is unexpected cardiac death with symptoms of ischemia. Type 4 is MI associated with PCI or stent thrombosis. And type 5 is MI associated post-cardiac surgery. Type 2 MI, again, there are different context to it. What is the mechanism? How does it happen? So there's a little bit of more discussion nowadays about type 2 MI. So you need to know about a little bit of type 2 MI and how to manage it. Type 1, yes, it is easy to identify, easy to manage. Type 2, where the new questions will be, right? So I would recommend to read about it in a little bit more detail. What is the context and what is the mechanism of it? Okay, not going in detail because it will take time. There's nothing rocket science. You need to know about this table. How will you manage this case? Now, anybody want to volunteer? It's the easiest question, probably the final MBBS question, but let's see how many things you get correct. There's 3 marks, so you have to talk about 3 important points that you cannot miss.
The first stabilization of the patient. Since the patient is tachypneic, I would like to initiate on the non-invasive ventilation. And since the patient also got pulmonary edema, after that, the definitive management would be to go for PCI stenting of the occluded arteries.
All right, I got 2 answers.
Agree with the stabilization of the patient first. We'll go with A, deciding whether to support with non-invasive ventilation or to proceed for intubation, as the patient is also shocked. Second thing, to start the pressure as well, to support blood pressure and to help him with the cardiogenic shock that he's currently on, while doing rapid alert to the cath lab, or possible BCI, primary BCI.
Okay, let's see.
Loading dose of the medication with ecosprin clopidogrel. So.
All right. So this is a very broad question. Patient with MI, how will you manage? So you have to talk about general management and specific management and management of complication. I'm saying this format because you will not miss anything, right? Okay. General management, taking care of airway, breathing, circulation, whichever is lacking, you optimize that. Specific management for ACS is primary PCI, antiplatelet, timely antiplatelet. That's a specific management, and look for any complications if there are, right? Whether as somebody said about the cardiogenic shock, you have to optimize the inotropy, you have to optimize the vasopressor, fluid balance, and all those things as a complication management. If there is an associated arrhythmias, bradycardia, pacing, all those things. So you need to talk about, when they ask about such a question, how will you manage a case of acute MI? So first of all, General management, optimizing airway, breathing, and circulation. Whichever is lacking, we will act on it. Then specific management includes timely antiplatelet and primary PCI if it is feasible, or if it is your center allows it. Otherwise, timely thrombolysis if it is ST elevation MI within that time frame, and look for complications of MI, which includes, we'll talk about it. The next slide is about it. So there are three different phases, three different approaches, which needs to be combined together, right?
Okay.
Yep. Okay. Thrombolytic therapy within 12 hours of onset of symptoms for whom the reperfusion or primary PCI cannot be performed. That's the indication for thrombolytic therapy. They can ask you about it. What are the investigation will you do in this case? Can anybody elaborate? Again, you need to talk about at least three important things that needs to be ticked off.
Need to take a sample for cardiac enzymes, definitely.
Yep.
And yeah, we need an urgent bedside echo to assess for the ventricular function and to assess for complications, possibly acute complications of MI, like Asperger, maybe having which actually in scene of myocardial infarction with heart failure, we would expect that there is some valvular dysfunction or LV systolic dysfunction. There things we need to
All right, you're correct. So you need to do some specific investigation to diagnose, that is the cardiac biomarkers. You need to do some echocardiography or radiological studies to make sure that what is the cardiac function, which segment is involved, and is there any complication if there's pericardial effusion or something associated, and others, which includes the ABG and chest X-ray. If the patient is going for a procedure, then we may need white cell count, sorry, the full blood count to look for hemoglobin, coagulation profile to make sure that the patient is not thrombocytopenic or coagulopathic, and also look for other organ dysfunction, which includes the renal function and a liver function. Make sure that there is no complications associated with the MI, right? So that will be the complete set of answer. But most important is the cardiac biomarker. You cannot leave it. Echo, you cannot leave it. Rest of the things like a complete blood count, coagulation, if the patient is going for a procedure, and thrombocytopenia, rule out with the platelet count, and all those things needs to be talked about. But these two you cannot leave, right? Now, what are the complications of acute MI? Anybody want to volunteer?
Yes.
yeah. Okay.
Yes,
Go ahead.
Dr.
You can talk about it. Yep.
Yeah, we can say like acute, then subacute.
Yep.
Like acute complication like arrhythmias, cardiogenic shock. The others like subacute pericarditis, post-MI pericarditis. Then we can mention the mechanical complication like valve dysfunction, papillary muscle rupture, free wall rupture.
Okay, that's correct. Nice. All right, let's see. I mean, you can say acute, subacute. Mine is different classification, but we are welcome to do any classification that you want, right? I say it as ischemic, electrical, mechanical, and delayed. Ischemic is angina, reinfarction, or extension of the infarction. Electrical is arrhythmia, heart block. Mechanical is cardiac arrest, thrombotic or embolic complication, heart failure, cardiogenic shock, mitral valve dysfunction, LV aneurysm, pseudoaneurysm, cardiac rupture, septal free wall rupture, RV failure, LVOT obstruction, and delayed is pericarditis and restless syndrome. So you don't need to remember all those things. If you remember a structure to do it, as one of you guys just talked about it, If you remember a structure to do it, then you will easily reproduce it in the exam. If you don't have a structure, you will be very vague about talking about arrhythmia, then left ventricular free wall rupture, and then you forget about everything else. So you need to have a structure to answer it. All right. The patient underwent PCI. Still, he is in persistent shock. What can be the possible causes of shock? In a patient who had MI, post PCI, is still shocked. What can be the causes?
Very common cause that should be considered is ongoing LV dysfunction and
Yes.
myocardial stoning. Yeah, both myocardial infarction or post-reperfusion injury again. This can be a cause for persistent cardiogenic shock post PCI. Again, we should rule out complications of PCI like wall perforation and pericardial tamponade.
Okay, that's correct. All right, so acute systolic failure, as you said, reperfusion injury arrhythmias, that can be the cause, bleeding, retroperitoneal bleed with the approach, PCI, cardiac tamponade, the patient can have septic shock and hypovolemia, whatever you can tell, but you need to talk about the most common thing that happens most commonly. So acute systolic failure,
Yes,
ongoing.
very important to remember about the possibility of combined shock.
Yes, correct.
Correct.
Yeah. That's very correct. So you can have a combination of everything. Not everything, but few of the type of shock in this case. Yep. All right, that's pretty easy. What are your management priorities for this patient when he has a PCI already and now he's shocked? How will you manage it?
Continue with vasopressor support.
Mhm.
And by this time arranging for a second line management, which will be assisted device like intra-aortic balloon pump, for example,
Correct.
or
Yep.
ventricular assisted device
Mhm.
to be considered. And meanwhile, again, we can repeat our assessment again because maybe he had both PCI primary, second MI due to occlusion of the stent, and maybe he will require even CABIT if he in the reassessment found that he's still having significant coronary artery disease.
Okay. All right, let's see. First of all, pharmacological. So you need to put some inotrope to improve the inotropy and consider SS devices, probably IBP, non-invasive ventilation, invasive ventilation as per the need, and then escalate based on what the patient needs. You definitely need some cardiac output monitoring system, whether it is a PICO or whether it is a PA catheter, whether you do echocardiography, but he needs a cardiac output monitoring system. The other part is assess fluid responsiveness for this patient, whether he's hypovolemic or not, gives some more fluid. Because the scenario is evolving, you have done the ABC part of it. You don't have to talk about general management. You have to talk about specific management in this case, which includes monitoring and what you do, which includes monitoring to start with, and then fluid assessment, inotropy, and assess devices after that. To help with the breathing and also to offload the left ventricle, you can use non-invasive ventilation if the patient has pulmonary edema associated with it. All right. Now the question was how NIV help in management of cardiogenic pulmonary edema. So it decreases the myocardial preload, decreases the afterload, it re-expands the flooded alveoli and improves the VQ scan, reduces the work of breathing, and reduces the heart rate by increasing the parasympathetic tone in response to inflation of the lung, which is probably a physiological explanation, but you do get a low heart rate when you put the NIV on the patient if he's not restless, then the heart rate does come down because of the indirect effect to the heart, like it decreases the preload.
Valsalva-like, yeah, it will cause Valsalva-like.
Yep. Yep. That's the other effect that it can cause. So if the patient is on NIV, they can ask you about the non-respiratory uses of NIV, or what are the other benefits that you get with NIV. So it will be the heart-lung interaction with the NIV, where you decrease the preload, decrease the afterload, improve VQ mismatching, and reduces the work of breathing. As I told, these are the list of things you need to know. These are the 5 functions that the NIV does in case of respiratory failure, in case of pulmonary edema. Okay. Now echo done, there was no pericardial effusion, ejection fraction was 20%, globally poor systolic function, started on noradrenaline, dose escalated to 0.2 microgram per kg per minute. Despite this, the BP remains low. He did not improve on NIV, and now he was put on invasive mechanical ventilation. What is your plan on management now? So additional mechanical circulatory support, because initial conservative management or initial pharmacological management is not working. We'll escalate to circulatory support, start with IABP, that will buy you some time, and think of putting the patient on ECMO or a ventricular assist device. Okay. The patient was on IABP. Now, they are very fond of asking about IABP waveform in the exam, whether it is a CBS or whether it is a CCS. Okay. What are the potential complications of IABP? Anyone want to volunteer quickly?
Limb ischemia, air embolization in case of rupture of the balloon, and malfunction of the IAPP, like early insulation or early deflation or late insulation, late deflation, affect the mechanics of it. It can affect the myocardial perfusion, increasing the afterload, and bleeding, of course.
I mean, common things again happen commonly, so you have to start with the common things, as you rightly said: limb ischemia, bleeding, possible aortic dissection, balloon rupture, gas embolism very rarely, bowel ischemia, surgical site like site infection. These are the usual complications. You can talk about it in a different way, like at the time of putting it, maintenance, and removal. The 3 stages of that. So you can talk about it at the time of putting. You can damage arteries, surrounding structure. Then on the maintenance, it can have all these things that we talked about, and post removal, it can have limb ischemia because of migration of clot and etc. So design your answer based on what you feel comfortable answering. I always like a pattern of answer so that I don't miss answer bits in there. What are the pathophysiological consequences if IABP balloon inflates too early? So now they are talking about abnormality. I'll talk about that in detail. There are 5 types of abnormality that is there in IABP or associated with IABP. So if it inflates early, what will happen is there will be premature closure of the aortic valve, increases the afterload, yes, and decreases the oxygen supply to left ventricle due to the decreased diastolic perfusion time to the LV, and the purpose of whole IABP is not solved. Okay, we'll go in detail about it. So they can ask you about the waveforms that you see. What is the augmented diastolic pressure? What is the assisted and end diastolic pressure? What is the role of it? So the diastolic augmentation helps in coronary perfusion, and that pressure is called as the assisted end diastolic pressure, which is lower than the real end diastolic pressure. What are the indication of IBP? They can ask you. There's a long list of it. So, but again, you need to have a classification format for the answer. So there are 3 grades of indication. Number 1 is to wait for recovery or bridge to definitive procedure. Number 2 is a prophylactic use, and there are some experimental use. So either so wait for recovery or bridge to definitive procedure, where you have a patient who has failed to come off bypass, patient with aortic stenosis, severe mitral regurg, VSD, or cardiogenic shock, which are waiting for PCI, bridge to definitive intervention. or pulmonary edema in spite of maximal medical management. These are the breathe to recovery or breathe to particular definitive procedure indication. Prophylactic use in high-risk PCI that can be used, or high-risk cabbage that can be used pre-operatively, pre-procedurally. There are some evidence coming up that are used in Takotsubo cardiomyopathy and neurogenic stress cardiomyopathy post-subarachnoid hemorrhage, where you have a low functioning LV, where the IABP is a temporary procedure to give time for the LV to recover, right? They can ask you about contraindication, absolute and relative again. Anything abnormality to the aortic regurg or aortic aneurysm, these are the absolute contraindication, aortic dissection, sepsis, uncontrolled coagulopathy, and there are a few other relative contraindications that you need to know. So this is the starting point, indication, contraindication that you need to know. Then the abnormality, complications again. We talked about that. I'm not going in detail. Abnormalities of the ECG, abnormality of the IABP. As I said, there are 5 abnormalities that is asked in the exam. Early balloon inflation, late balloon inflation, early balloon deflation, late balloon deflation, and poor diastolic augmentation. There are 5 different abnormalities that can be there, and there are 5 different pathology associated with it. Early balloon inflation, as we talked about, it increases the afterload. Late balloon inflation decreases the diastolic augmentation because you get less time. Then early balloon deflation fails to decrease the myocardial oxygen demand. Late balloon deflation again increases the afterload, and poor diastolic augmentation not adequate to optimize the coronary perfusion. Slightly in detail, this is early balloon inflation. As you can see, it inflates before the diacritic notch. What will cause is it increases the afterload, thereby increases the left ventricular oxygen demand. It decreases the diastolic perfusion time, decreases the LV oxygen supply. As the LV is still contracting and squeezing the coronaries, like it is still contracting, it will not push blood into the coronaries, because at that time, if the IVP balloon inflates while the LV is still contracting, it will not push blood into the coronary, and there will be no effective coronary perfusion, improvement of coronary perfusion. Okay. Late balloon inflation, as you can see, it should have inflated at the diacritic notch, but it's beyond that. So there is decreased diastolic augmentation. It doesn't go there. It stays here below that. So decreased diastolic augmentation. There will be decreased coronary perfusion. Okay. Then the early balloon deflation. So it deflates early rather than staying there and going down. What does it cause? Is too early balloon deflation. The aortic pressure has time to equalize to the unassisted level. There is no reduction in the duration of left ventricular isovolumetric contraction. So the isovolumetric contraction of the left ventricle is the major part where most of the oxygen is used. So if it deflates early, there is no reduction in the isovolumetric contraction phase of the left ventricle. So there is no reduction in the myocardial oxygen demand, right? But there is still some diastolic filling because you have augmented diastolic there. It happens, it inflates at the right time. So you'll get some coronary perfusion. But as it deflates early, the left ventricular isovolumetric contraction phase is not decreased. It remains the same, and the oxygen usage or demand remains the same. The balloon deflation or late balloon deflation, what will it cause? It causes increased aortic end diastolic pressure. So there is increased afterload. There is increased oxygen consumption by the left ventricle. Okay. So it increases the afterload again because it stays inflated for a longer period of time. Late balloon deflation, we talked about that. Yeah. Unit 3. Now, despite the best possible effort, his blood pressure did not improve, and the patient suddenly developed an asystole or cardiac arrest. After 8 cycles of CPR, there is ROSC. 48 hours post cardiac arrest, sedation was stopped, but the patient was unresponsive. GCS of E1, M2, V1, pupils are equal reactive to light. Corneal reflexes are present. This is only at 48 hours. Okay. He's breathing spontaneously on ventilator and coughs on suctioning. You observe myoclonic jerk in the patient. The CT brain is performed at 48 hours is normal. So that 48 hours comes up repeatedly. That means it has some significance because your prognostication doesn't happen till 72 hours. So this is an early time to have any CT or to judge anything based on the clinical finding, right? How will you manage this post-cardiac arrest patient from the start, okay? You need to have targeted temperature management. You don't have to do therapeutic hypothermia nowadays. In my setup, we maintain normothermia, and you need to have neuroprotective measures. These are the two important things that you do. So targeted temperature management and neuroprotective measures for 72 hours to make sure that the patient get adequate time to show any recovery sign. Now, causes of myoclonic jerk and its prognostication significance. Anyone who can tell what is the prognosis if the patient has myoclonic jerk?
Usually associated with poor prognosis, especially if it is status myoclonus.
That's absolutely correct. So if it is status myoclonus, it has a poor prognostic value. If you have only isolated myoclonus, it doesn't count, right? The word is status. Status myoclonus has a poor prognostic, is a poor prognostic indicator. Now, why does it happen? Usually because of the anoxic brain injury. No rocket science there. How will you prognosticate to his family? All right. The patient has anoxic brain injury. The prognosis is probably poor, but difficult to say at 48 hours because the guidelines always recommend 72 hours or longer, right? We continue to support this patient till 72 to 96 hours to have more assessment and give you a more reliable opinion. That should be the outcome of it, right? If somebody asks you how you prognosticate at 48 hours, it's still short of the recommended time, which is 72 hours. And you cannot prognosticate a patient at 48 hours. You need more information. You have to wait till 72 to 96 hours that you have to tell. Suppose you start telling about, no, the patient has poor prognosis and he will die because of the myoclonus. You don't take the time frame into account, then you are in trouble. You have to be very vigilant about what time frame they're talking about. It's specifically said twice in that vignette that 48 hours and 48 hours. So you cannot prognosticate at that time. Okay. On day 5 cardiac arrest, the patient remains
Neuroprognostication. So
sorry.
for neuroprognostication, isn't 48 hours a cutoff, sir, rather than for 72 hours? Like after 48 hours post cardiac arrest, we normally start the neuroprognosis.
No,
The
no, no. If you
multimodal.
look at the guideline, the
Okay.
ESICM guideline, it is 72 hours or beyond
Okay.
that, not 48. Okay. So
Okay.
saying that you need to read about that guideline. It is a very, very well written guideline. I think it is there in the study material. If not there, it should be in the neurology domain, but I think it is there in cardiac arrest domain. So if you look at that guideline, you need to know in and out of that because that is a position paper from ESICM, very well accomplished, and the whole world go by that guideline, right? It is a very, very important paper. At least the table there is a flow chart there for prognostication. You need to learn that in and out, okay? It's a very important paper to look at. Okay. On day 5 after cardiac arrest, the patient remains unconscious, jerks has disappeared, but the brainstem reflexes are absent now. How will you proceed further? All right. In this case, the patient has a poor prognosis. On day 5 of sedation, not doing anything, brainstem reflexes are absent. So probably we'll do some brain death testing or apnea test, and we need to do some ancillary test if required. Okay, that means you need to do brain death testing in this patient. What are the prerequisites? Very important question in the exam. You need to know all these prerequisites. So patients should be normothermic, normotensive, exclusion of all sedative agents, no residual neuromuscular paralysis, ability to examine the brainstem reflexes, and ability to perform apnea test. These are the prerequisites to do the brain death testing. Okay, you need to know about this. Name 2 landmark trials related to therapeutic hypothermia targeted temperature management in out of hospital cardiac arrest. I mean, they may not ask you this, but again, ESISM is very heavily involved in this trial. This is like a very important topic and important, what you call, sentiment for them. This post-cardiac arrest prognostication trial. So the first one is the HACA trial. I think it came from Australia, probably, to my memory. TTM1, TTM2, and the HYPERION trial. So these are the important trial. You need to know about it. At least what trial has shown what. So the HACA trial, it is a multi-center randomized 273 patients, which looked for out-of-hospital VF and VT, 24 hours of cooling to 32 to 34 degree versus the usual care. And it showed some favorable neurological outcome, but had some intrinsic issue about it. So you need to read in detail. So the summary of these trials are good in Life in the First Lane. If you look at, there is a one-page summary of all the trials there. Life in the First Lane. TTM1 trial, again, 2013, 939 patient. They prompted the idea that normothermia is probably the way to go. Then that is followed by a TTM2 trial, which showed that maintaining a temperature 36.5 to 37.7 for 72 hours post-ROSC has shown no difference in mortality or any morbidity compared to a hypothermic patient. So that's the current standard of care, widely accepted in practice. And there is an HYPERION trial, which is, again, I think it is from the ESICM, probably, to my memory, 584 patients, and they looked at various outcomes in that. But it has shown some significant improved neurological outcome in the hypothermic group. So you need to know which trial supported the hypothermic arm. They are usually the old trials like the HACA trial and the HYPERION, but the TTM1 and TTM2 are in favor of normothermia. That's where the current practice is. All right, that was the last slide from me. Any other questions, please, if you want to ask? I'll take these questions quickly. Indication
Just
for
a common question, Dr. Santa. If I did not understand the question well, can I ask the examiner in the real exam?
Yes, you can. It's a good practice to ask them, sorry, sir, I could not understand. Can you please explain again? So you are very, very welcome to ask. Right? Because this is a game or this is a game breaker. Because if you answer in a wrong path without understanding the question, then you will be in a rabbit hole. And then it will be very difficult for you to go in the right direction, because it is a objective type of exam. You have to answer or attempt the answer to go to the next stage. If you are stuck there, they will not go to the next stage, right? Or they may, but you lose time for it. Okay.
Okay, thank you.
Somebody has asked about drug and doses in the last question. So drugs, yes, usually they don't ask about the doses unless it is very, very obvious or very, very common drug. Do we need to specify to be specific with EEG changes? Yes. So you need to know about EEG changes. Sorry, ECG changes. I didn't understand what was she asking. But yes, I think Tapas will go through the ECG part. If not, we'll go in the cardiothoracic domain. How to explain the ECG. We'll talk
It was
about that.
in
Okay.
regard with the question asked that regarding myocardial infarction, how will you diagnose? And so as we stated that ECG changes raise troponins. So do we need to specify? The next question was asked like that. So in the earlier question, I was expecting whether we should talk about whether ST elevation like at least 1 mm in 2 consecutive weeks. I just wanted to know how should we answer in the previous question.
So in that context, you can tell these are the changes in the ECG, which is suggestive of significant ischemic changes in that case. But I mean, it's very hard to, replicate a verbal exam. In this case, they will show you an ECG, say that this is the ECG. What is your finding in the ECG? Right? That and what is your diagnosis? So you need to be very specific. If there is a roaring ST elevation in the ECG, you have to talk about it. You cannot miss it. You cannot say ECG changes in general for that. You have to tell there is ST elevation in these leads suggestive of this territory infarct in this patient. So you need to talk about it. Is it we type answer? No, you don't type. You talk about the answer in CCS. All right. If there are no further question, then I'll ask the person to go through the CBS, please.
Yeah.
The person. Yeah.
Thank you, Dr. Sanant, for extensively discussing the two CCS, and I hope all of you must have been little bit tired after these two CCS. So you can stand up from where you are sitting and then take your seat, because we are again going into something which is very important, and I normally name it as CBS is the ticket to success. It's not the ticket to success, I would say, completely, because the CCS also carries the important role in getting the success. But believe me, the feedback of all the candidates is that the CCS is somehow they are able to answer, but CBS is the most difficult because it's the time management, and CBS is something people know, but limited time sometimes keeps them thinking about what to answer, how to answer, and then they lose the precious time. So that's the reason why I have make it work smart. It is the ticket to success, and practice, practice, practice. This is the mantra of success for the CBS. So let's start with the first question. I have made some of the domains from which normally the cardiology CBS questions come. So the first question, if you have all attempted the mock test that, or the first question set that we have shared yesterday morning, the first question is related to most important in cardiology, that is ACLS rhythm or cardiac arrest. So the question states that you got a call to see a patient on the ward who has a return of spontaneous circulation, that is ROSC, following a cardiac arrest. The patient is groaning. Now on initial assessment, you find the patient is having patent airway, bilateral equal chest movement with good air entry. Respiratory rate is okay, 18 breaths per minute, with saturation of 94% on high flow oxygen. Now, the heart rate is 45 per minute regular with poor pulse volume, and BP is definitely low, 57/30 millimeter mercury. Patient is conscious but not fully alert. RBS is 5.5. The normal range they may mention in the question, or it may be you have to calculate from your own. So one clue from the very beginning, you have to remember some of the conversion factors like RBS, PaO2, PCO2 from the kilopascal to millimeter mercury. Then you have to also convert from the milligram per deciliter creatinine urea to millimole per liter. So there are some of the conversion factor you have to remember, you have to mug up. In the exam, they normally provide in the question, but in the hustle bustle, like you may not get the time to ask them or check the normal range in the CBS. So you have only limited 10 minutes, 12 minutes time for one station. So better you have to know the conversion factor of some of the important biochemical parameters or some of the gases. Now, in this patient, post ROSC, when you did the ECG, ECG is showing this. Now, I want the answers from all of you to keep you engaged. Otherwise, what will happen after this one and I would say 45 minutes of discussion or 2-hour discussion, you would be just get bored. So what is the ECG rhythm? What is the diagnosis? And what is the immediate treatment? Smart answers. Whatever you know.
Yeah, this is bradycardic rhythm.
Sorry?
That shows bradycardia with the progressive prolongation of PR interval.
Okay.
So the
What is
diagnosis, second degree heart block, Mobitz 1.
Okay.
What is the
And
last
what is
question?
the immediate treatment? Immediate treatment?
Immediate treatment, we can give atropine, 0.5 milligram to the maximum of 3 milligram. If no benefit, then IV infusions, noradrenaline or dopamine, or we have transcutaneous spacing.
Okay. Anyone who wants to answer?
So this is AV dissociation. This is a complete heart block with a ventricular rate of 45 beats per minute.
Interesting. Diagnosis?
This most likely posterior MI needs transcutaneous pacemaker.
Okay.
And then
Okay. In the
CCI,
treatment, anything new you want to add? Anyone wants to add? Okay.
Immediate pacing.
Immediate pacing. Okay. So I expect that everyone start talking, because in the exam, this is the normal the practice that people who don't utter the words, they feel little bit like shy, or they may be having verbal constipation. So they would say that, yes, I would be only talking about 2 lines, 1 line, and the examiner would be getting the hint that I know. But examiner is totally a layperson, I would say. These are some of the clues in our course we would be trying to share with you in between. It's not maybe core academic, but I would say these are some of the hints, some of the tips, some of the tricks that I want to share with you in between. People who always start with, I would start with, in my opinion, my patient is having, all these like statement making words or like sentences sometimes gets you good marks, and that these are the practices that you would be doing in our every week domains, all those discussions. Otherwise, on the real day of your examination, it may not be very prudent to expect from the candidate. So in my opinion, I would say in this question, it's a complete heart block. This is the ECG rhythm. I would explain why. Diagnosis, if I want to get 3 marks in this question, there are the full marks are 3. So in this question, my diagnosis would be, this patient is a post cardiac arrest patient with complete heart block with cardiogenic shock. This is the complete diagnosis. Complete heart block is not a diagnosis. Complete heart block is one of the diagnostic finding that I would be liking to share. Now, immediate treatment, as one of our colleague has already expressed, injection atropine 0.5 milligram, maximum up to 3 milligram. You have to mention this, maximum up to 3 milligram. After that, there is no point of giving atropine. Injection isoprenaline, injection adrenaline, fluid resuscitation, and transvenous pacing or transcutaneous pacing, depending upon the availability or the resources. This would be the complete answer to these 3 questions. Now, this is very interesting article just recently published in the October 2023. I want to share with you all. Type of post cardiac arrest rhythm should not be labeled. Though in our ECG, it was a complete AV dissociation, complete heart block that was clearly mentioned. But if we want to treat the post cardiac arrest rhythm, rather than getting into all the nitty-gritties of the ECG rhythm, I would be labeling it as post cardiac arrest rhythm and start treating. Now, what should be the protocol? Once you receive or you get the ROSC in your patient, if your patient is having hypotension, like in our patient, the systolic blood pressure is less than 90, you have to start with IV fluid bolus because this patient is having hypotension. Now, do not label this rhythm. It is mentioned here. Now, along with the measures of post cardiac arrest care, I would be starting vasopressor or inotropic agent based on the heart rate. If the heart rate is less than 50 per minute, I would be starting with adrenaline, titrating to the blood pressure. Now, if my heart rate is more than 150 per minute, that means patient is tachycardic but hypotensive. So maybe infusion noradrenaline or phenylephrine would be appropriate in my patient, and I have to again titrate the blood pressure. So this would be the typical management of a post cardiac arrest ROSC rhythm. Moving ahead, in the complete heart block, the ECG feature would be normally severe bradycardia, like in our patient, due to absence of AV conduction, and you would be getting frank AV dissociation with independent arterial rhythm and ventricular rhythm. That means atrium would be contracting on its own and ventricle would be contracting on its own. Now, this would be the typical complete heart block ECG. There is AV dissociation, and you can see here the P wave is 100 beats per minute arterial rate, and you can see the ventricular rate, this QRS complex, is around 40. So the arterial rate is 100 and the ventricular rate is 40. So this is typical AV dissociation, and the patient is having severe bradycardia due to complete heart block. Now, the perfusing rhythm in the patient, like in our patient, if the patient is conscious, that is due to junctional or ventricular escape rhythm. So there is some amount of junctional activity happening in my patient, and the ventricle is still able to get some of the escape rhythms, and that's why the patient is conscious. Alternatively, if you are not going into like the treatment plan immediately by transvenous or transcutaneous pacing, then the whatever ventricular like perfusion is happening, that would be leading to syncope, because if the perfusing rhythm is not there or self-terminating, so you would get syncopal attack in between in these patients, or sudden cardiac death if the rhythm, the ventricular rhythm with which this patient is right now having, so that it would be the terminating for long time, definitely the patient is going to die. So this is something you should remember, and in cardiology section, definitely you are going to get one or two typical ECG questions. Maybe it would not be the direct ECG question, but one part of the question would be based on the ECG. So that's why I have almost 4 to 5 ECG questions in my CBS from the cardiology. Now, some clues to all of the attendees here. Whenever you are asked to read about ECG, it is a little bit difficult to remember all the things. So we always suggest our candidates to have their own question bank. How you should prepare your own question bank. So the questions normally that is asked from the ECG are MI, all types of MI. You have to remember the ECG findings. Hypothermia, environmental factors that may be asked in your exam. Electrolytes, hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, arrhythmias, supraventricular arrhythmias, the ventricular tachycardia, the atrial fibrillation, the arrhythmias, they can be a favorite question in an exam. Heart blocks, first degree heart block, secondary heart block, complete heart block. Pulmonary embolism, the ECG finding. Pericardial effusion, pericarditis, left ventricular hypertrophy, some of the syndromes like WPW syndrome, Wallenstein, Brugada syndrome. So in this, if you want to highlight ECG patterns asked, you can see here arrhythmias and peri-arrest rhythm. One of the question I have already asked you. Heart block, I have already asked you. Ischemic rhythm, this is related to MI. Metabolic rhythm, already I have told you. Hyperkalemia, hypokalemia, hypercalcemia, hypothermia, digoxin toxicity, TCA toxicity. Pacemaker rhythms, again I have one question related to that, pacemaker rhythm. Syndromic rhythms, I have already mentioned Wallenstein, Brugada syndrome, short and long QT syndrome, WPW syndrome, pulmonary embolism, pericardial effusion, dextrocardia. I have question related to that. So if you are thorough in these questions, you start collecting the ECGs in your question bank on your laptop, on your mobile, on your the iPad, and start revising in between. So on the day of examination, you would not be confused. Otherwise, it is very difficult to remember the typical signs, the telltale signs of the individual ECGs. So high priority domains from this question, cardiac arrest, you have to know from A to Z. It's not only ECG, rather post cardiac arrest management, SCLS, SLS rhythms, algorithms, and ECG. So this is question number 1. Question number 2 comes from pharmacotherapy. renal, or I would say one ECG also based upon the renal or pharmacotherapy. So the question states that a 62-year-old woman has been admitted to the ICU with hypotension and bradycardia. So this is the finding. Following a 4-day diarrheal illness with vomiting. She is in acute renal failure with a serum potassium level of 6.9. Her medication history is unknown. Her ECG is shown, right? What abnormalities are shown on the ECG? What is the most likely cause of bradycardia? Anyone?
Yeah,
Anyone?
there is a bradycardic rhythm with we can see variable block. يعني the atrial P wave is more than the QRS complex with narrow complex. With as we can see here, the T inversion in the lateral leads. ST depression, sorry, ST depression.
Okay. So what is the most likely cause of these ECG changes?
Bradyarrhythmia can come with hyperkalemia.
Okay. Very good observation. But I would be giving you half marks because the things that is the mark fetching, ventricular bradycardia you have mentioned, atrial tachycardia, AV blocks you have mentioned, reverse tick ST segment changes. I would show you. You can see here. You can see here. You can see here. And this is most probably due to digoxin toxicity, and that is exacerbated by acute renal failure. So knowingly they have not mentioned about the digoxin, that this patient is on digoxin. Her medication history is unknown, but they have mentioned the potassium level is high with creatinine level is also high, acute renal failure, and that is a 4-day diarrheal illness with hypotension and bradycardia. Definitely this patient is right now showing the digoxin toxicity. So this is the complete answer to get full marks. In toxicity, one is supraventricular tachycardia, slow ventricular response due to decreased AV conduction. So these are the classic digoxin toxin dysarrhythmia. If somebody would be asking you what is the most common abnormality in digoxin toxicity, it is PVC, premature ventricular complex, like ventricular bigeminy and trigeminy. Sinus bradycardia, slow atrial fibrillation, any type of AV block that can be done, like induced by the digoxin toxicity. Regularized AF, that means AF with complete heart block, and there would be junctional or ventricular escape rhythm, and VT, that includes polymorphic as well as bidirectional VT. So this is the complete ECG feature, and you can get any of that when the patient is having or receiving digoxin. Now, digoxin features or the effect doesn't always imply that the patient is having digoxin toxicity. That means the patient may be getting the ECG features if the patient is taking digoxin regularly. So that doesn't mean that you have to treat that. So that is the difference between digoxin toxicity and digoxin effects. So if you are getting a downsloping ST depression with a characteristic reverse tick or hockey stick pattern on somebody, you can see Salvador Dali sagging. I would show you the picture. So it's a typical digoxin effect on the ECG, and flattened, inverted or biphasic T wave and certain QT interval. So these are some of the digoxin effects on the ECG. Now you can see here, this is the classical reverse tick. You are just getting the reverse tick feature here. Reverse tick, STTU, classical reverse tick feature. This is the Salvador Dali. You can see Mostak sign, classical. Just easy to remember. If you are getting this type of feature in a patient who is taking some of the cardiac medication and patient is in the acute renal failure, the examiner is willing to or expecting that you should tell about patient is having digoxin toxicity or digoxin effect. Now, coming to the third question, this is related to, again, ECG. 52-year-old man has been brought to the emergency department, having been found collapsed next to a canal. He is dressed in multiple layers of cold, wet, and dirty clothing. He has heart rate of 48 beats per minute with blood pressure of 88 by 54 millimeter mercury. GCS is 9, E2, M4, V3. The paramedics have been unable to obtain a temperature reading. ECG done showed. What is the ECG finding? What abnormality is marked by the arrows? I have already shown you the answers. What are the causes for this type of waves? And what are the changes? This is the typical question they would be adding, because hypothermia people would be finding easy. But they are now expecting that you should know about the ACLS algorithm in a patient with hypothermia. So that's the reason they have clearly in multiple lines they have mentioned have been found collapsed next to a canal, cold, wet, multiple layers. Then patients, the paramedics have been unable to obtain a temperature reading. So most of the things they have given you clue. So this is again another the tip and trick that I want to share with you. In the CBS, just don't read the whole question and the clue. Sometimes you will be getting some of the words which would be directly giving you the answers. So you have to find out, and that's the reason practice helps you. So they say, wise men say that if your mind doesn't know, your eyes cannot see. So if I don't know what I have to find out in this ECG, so they have mentioned about cold, then canal, unable to obtain the temperature reading. So they have given you enough clues. And if somebody will be finding that hypothermia, this patient is in hypothermia, definitely the answer would be Osborne J wave. And that's the reason why they have given you the clue. So the next question is, what are the other causes of this type of waves? One is hypercalcemia, brain injury, subarachnoid hemorrhage, vasospastic angina, idiopathic ventricular fibrillation, type 1 Brugada syndrome, normal variant also. So sometimes early repolarization can cause this type of ECG changes. Now, some of the changes in the usual pattern of our advanced support algorithm. In case of hypothermia, no adrenaline or other drugs until the patient's temperature is more than 30 degrees centigrade. So this is, you have to remember, between 30 to 35 degrees centigrade, double the dose interval for advanced life support drugs. I would explain this. Now, you have to shock ventricular fibrillation or ventricular tachycardia up to 3 times if necessary. Then you have to wait till the temperature is more than 30 degrees centigrade. These are some of the changes in the pharmacotherapy, in the shock delivery, and also in the CPR style. Now, once the cardiac arrest is recognized, you have to continue, you have to start with BLS and ACLS, rewarm the patient as fast as possible, and rewarming is the best antiarrhythmic and inotrope. So if you always try to give some of the adrenaline or atropine or any other inotrope thinking that the patient will be reverted back, it is not going to happen. Rewarming is the best antiarrhythmic and inotrope in a case when the patient is having profound hypothermia and cardiac arrest. Look for and treat comorbidities, and also simultaneously you have to consider alternative diagnosis. Like we have multiple causes for getting Osborne J waves. Anticipate a prolonged resuscitation that could require significant multi-speciality input. By that, you have to call for help. It's not only 1 or 2 person, rather you have to involve many people, because it's going to take a lot of effort from your team. Now, there are multiple things I want to be just showing you the slides. I don't want to go into detail. In the deep fibrillation, you have to remember a few things. Defibrillation is less effective when you are getting hypothermia. For VF, VT, defibrillation may be tried, but yes, you have to think about that you have to give 3 times, but if it is unsuccessful, rather giving it multiple times, wait till your temperature reaches 30 degrees centigrade. If you think that if you are getting the sinus bradycardia or your patient is not able to get the required heart rate, you will be giving the pacing. No, pacing is generally ineffective. So do not try it. Try it if unless bradycardia persists when normothermia is reached. Sometimes hypothermia is causing the physiologic effect on the body by inducing sinus bradycardia. So you do not need to treat sinus bradycardia in this type of patients always. Ventilation, try to maintain the PaCO2. It should not be reduced also by giving more tidal volume, because that will cause cerebral hypoxia. And in the ABG, in your patient, you have to aim for normal CO2 on ABG, not corrected for the patient temperature, rather the usual temperature. Intubation, sometimes when your patient is having perfusing rhythm, doing intubation maneuvers can also precipitate VF, because the patient is having so stressed and the temperature is so low. Doing the intubation also sometimes can precipitate VF. Resuscitation drugs, normally the drugs are often ineffective. That's the reason why hypothermia management is more important. You have to maintain the temperature and increase the temperature. That is the best drug that you can do. So you have to, all the drugs should be withheld below 30 degrees centigrade. And then you have to give twice the time interval, because the metabolism is actually taking long time. So you have to wait before giving the second dose, or the temperature is right now 35 degree, or circulation is restored. Now, adrenaline would be given about every 8 to 10 minutes once the core temperature is above 30 degrees centigrade. And the reason I have already mentioned, it takes little bit longer time to reach the core, and the metabolism is also getting delayed for the adrenaline. Chest compression, hypothermia would be causing muscular stiffness. So chest compression may be harder work than normal. Rewarming can be passive, can be active. But if your patient is having perfusing rhythm, like in our patient, passive measures may be sufficient. But passive measures will only achieve rewarming in a patient with effective circulation. If your patient is in arrest, do not go for passive measures, rather active measures of rewarming. Remove all the wet clothing, dry the patient, cover the patient head, ensure warm environment. So these are some of the things that you have to remember. And finally, for the active rewarming, cardiopulmonary bypass. This is the therapeutic maneuver of choice. And this could be done by femoral or aortic right atrial bypass. So this is the some of the key changes to the standard ALS management in hypothermia. Now, question number 4. 75-year-old patient with ischemic heart disease has been admitted to the hospital with recurrent syncopal episodes. You have done transthoracic echo that showed moderate biventricular dysfunction, and cardiac angiography you did that demonstrated a chronically occluded right coronary artery with diffuse coronary disease. The drug history of this patient is bisoprolol, ramipril, spironolactone, and furosemide. You inserted a temporary pacing where? So it's a ischemic heart disease patient with recurrent syncopal attack, and you did the transthoracic echo and angiography, and you did the temporary pacing. Now this is the ECG. Correct? Now the question is, how could you describe temporary pacing wares using first 3 positions of the British pacing and electrophysiology group generic pacemaker code? Then, with reference to the pacemaker functionality, the second question is, what is rate modulation? Third question would be, what actions should be taken when you defibrillate a patient with permanent pacemaker? Any answers to this question, or I would be going ahead? You have to, in this question, I want to emphasize that for the pacemaker, you have to read and understand, because there would be a question sometimes. And this is a preferred domain in the cardiology. So in the British pacing and electrophysiology group, the first 3 positions, VVI, paced ventricle, sense ventricle, and inhibited. VVI is for demand pacing. Now VOO That means paced ventricle, but after that OO, or I would say 0, that means no sensing and there is no need of any inhibition. So it is like all is right now 0 or O. Now, the second question is, what do you mean by rate modulation? Rate modulation is the ability of the pacemaker to alter the rate based on the physiologic demand of the patient. So if the patient is requiring the heart rate to be increased, then the pacemaker would sense it and then it would be alter the rate. Now, some of the changes, key changes when you try to defibrillate a patient in your ICU, but the patient is already having pacemaker, permanent pacemaker. So some of the precautions that you should remember, the defibrillator pads should be placed as far as possible from the pacing box. This is question like answer number 1. And then the pacemaker must be checked as soon as possible post defibrillation to check whether the pacemaker settings is okay and the functionality is still there. Otherwise, what will happen? You will do the defibrillation and post defibrillation, the pacemaker starts not working. So that is not what you want in your patient. Now, some of the clues related to pacemakers, I know you have to read in detail, but I just want to show you. There may be question in your CCS as well as CBS related to pacemaker, single chamber, dual chamber, biventricular pacing or pacemakers. So you need to remember what does it mean. Now, the modes of cardiac pacing, letter 1, letter 2, letter 3, letter 4. There are 4 letters normally in a cardiac pacing. Letter 1 is always the area being paced. Letter 2 is sensed. Letter 3 is response of the pacemaker to the sensing. Like the O stands for none, I stands for inhibiting, T stands for triggering, and D stands for dual, if both the two things can happen. Now letter 4 is rate adaptiveness. O stands for none, R stands for rate adaptiveness. So this is the typical model that you should remember, or the nomenclature that you should remember. And these are some of the single chamber modes: VOO, VVI, AOO, AAI. So you have to remember. I am just giving you example of VOO. V means the first one is pacing. So pacing is in the ventricle. O means sensing is off. O means the third one is response to sensing is off. That means in this mode, a pacemaker paces at a programmed rate regardless of the increasing activity of the heart. So this is VOO. VBI is pacing in the ventricle, sensing in the ventricle, and I is inhibit. That means pacemaker can sense the electric activity and withhold pacing when not required. Moving ahead, some of the dual chamber modes that can be divided into tracking mode, non-tracking mode. I'm just giving you example of DDD. What do you mean by DDD? D is dual. That means pacing in the atrium and ventricle. Then the other D, second D is sensing in the atrium and the ventricle. And the third D, both inhibiting as well as triggering. So this mode is fully capable of adapting to the increasing heart rhythm and mimicking the normal conduction as much as possible, like in our ICD, the combo devices normally we put for our the patients. So DDD and VDD, pacing in the ventricle, not atrium. D, again the sensing is there in both atrium as well as ventricle, and again the D inhibiting and triggering. So these are some of the things that you should remember. They would be normally posting a question in your exam. Question number 5, straightforward question. 56-year male, non-diabetic, presents to ER with 7 days SOB. Identify the abnormality. How will you manage this? Any answer? This is easy question. They may show you a short clip or video in your real exam, but in our the practice test, we have only shared the screenshot. They may play the video.
Pericardial tamponade with the diastolic collapse. Pericardial centricis would be the management.
Yeah, okay, perfect. So pericardial effusion, suspicious of tamponade, because there is like we can get the hint that patient is having diastolic collapse, and depending upon the clinical scenario, definitely pericardiocentesis is the treatment of choice. Question number 6, straightforward. 56-year male, chronic smoker with uncontrolled hypertensive. Scan the question, uncontrolled hypertensive. This is the clue, number 1. Presented to ER with acute onset chest pain radiating to the back. Clue number 2. Acute onset chest pain radiating to back. You did the CT scan. Hardly out of 10 causes, you straightforward send the patient for CT scan. One of these is the answer to this question. So 3, clue number 3. Identify the abnormality, management. Smart answers?
Aortic
Aortic
dissection with fall
dissection.
lumen.
Yes. And management?
Heart rate and BP control, sir. If it's type A, surgery.
Yeah. So aortic acid dissection, heart rate and blood pressure control as rightly said, and also depending upon the type, you have to opt for surgical opinion. Correct? 45-year male admitted to the ER with acute onset chest pain and shortness of breath for 6 hours. An ECG taken in ER. What is the diagnosis? What is the definitive management? Look, so many questions on the ECG as well as the clinical finding. Any answers?
Acute ST elevation, am I in the anterior lead? Or the treatment is, definitive management is BCI if it's available, or thrombolysis.
Perfect. So this is the full answer, anterior wall MI, PCI. Straightforward, you will get like full marks. Just remember the area of infarction, ECG leads and infarct related artery. They may ask you something or other. Inferior, 2, 3 AVF, anterior, V2, V3, V4, lateral, 1 AVL, V5, V6. So likewise, I'm not going into detail, but you have to keep your question bank ready from now onwards. Each domain in our like TRICS 2, we have a domain. So in that, you have to keep accumulating the CBS questions weekly, so that at the end, along with our domain discussion, debriefs, you can accumulate your own question bank. That would be almost 300 questions. So 7 days before, 10 days before your real exam, when you start revising, it would be almost 500 questions, CBS questions. And do you think anybody can like ask anything more than those 500 questions? I don't think so. So critical care would be just, you will be getting, oh, this is the question I have done in the month of January. This is the question I have done in the February. So it would be tip of the tongue. And the examiner would be really like happy to answer, like get all those answers from you. Question number 8, related to pharmacotherapy in the cardiology. It inhibits phosphodiesterase 3 enzyme by decreasing cyclic AMP hydrolysis. It works as an ionodilator. I have already mentioned the answer. Which drug we are talking about? It is milrinone. And what is its effect on the right side of the heart? So they are specifically mentioning that you have to tell about the right side of the heart action of milrinone. So it's a pulmonary vasodilator. That means it would reduce the afterload of the heart, and also it's a peripheral vasodilator. That means as a result, what would happen? The preload to the right ventricle is also reduced. So this is the result at which the patient would be having right ventricle would be better contracting now. And there is also the third action would be lysotropy. That means the relaxation, the muscle relaxation would be there. So these are the 3 effects of milrinone on the right side of the heart. And as a result, what would happen? The contractility of RV would be improving. And these are some of the pulmonary vasodilators: nitric oxide, milrinone, prostaglandin, sildenafil. And we all know the mechanism of action of each one. In the exam, they may ask you. Clear? Question number 9. What is the mechanism of action of this following drug? What are the 2 important side effects? What is, anybody?
Protamine will combine to the heparin and making like a salt that is without anticoagulation effect.
Excellent. What are the 2 important side effects?
Oh, anaphylaxis can happen with protamine. Protamine overdose can cause also bleeding.
Okay. So it's a highly cationic peptide, protamine, that binds to either heparin, or if your patient is on low molecular weight heparin, then it would bind to that to form a stable ion pair which doesn't have any anticoagulation activity, and this ionic complex is then removed and broken down by RES. What do you mean by RES?
Endothelial system.
Yes, reticuloendothelial system. So it will be removed from the body. Now, the side effects would be anaphylactic, pulmonary vasoconstriction. Protamine can cause pulmonary hypertension, bronchoconstriction as a result of anaphylaxis, bradycardia and the heart, negatively impact platelet function, interfere with coagulation factor leading to bleeding, decrease thrombin fibrinolysis. So these are some of the side effects or adverse effects of using protamine. Question number 10. A 70-year-old male presented with left side weakness of the body with right facial drooping. He has also painful red raised lesions in the hands and feet, as you can see in the picture, which have been progressively increasing for last 3 weeks, and also the patient is feeling unwell, low grade fever, generalized malaise and body ache. He has been treated with systemic prednisolone by his GP for last 2 months for polymyalgia rheumatica without any improvement. On auscultation, you have to scan this line. He has a loud pansystolic murmur over precardium. So they have given you so many clues. Left-sided weakness, stroke, painful red regions in the hand and feet, some of the skin lesions. Patient is having constitutional symptoms. On steroid for some of the vasculitis, rheumatic problem, and patient is having loud pansystolic murmur. Smart answers. What this patient is having?
Infective endocarditis.
And what is the treatment?
Treatment antibiotics.
Which antibiotics?
Yeah, antibiotics usually vancomycin will cover the gram positive.
Okay, so very good. So these skin lesions are consistent with, you have to remember, Osler's nodes, genuine lesion, Roth spot, and most probably diagnosis here is infective endocarditis. For the above patient, the next question, what is the indication for urgent surgery? I would be showing the answer in the next slide. What is your empiric antibiotic plan? Benzathine penicillin, flucloxacillin plus gentamicin and vancomycin. So you have to mention about benzathine penicillin, flucloxacin, gentamicin and vancomycin, empiric antibiotic. Now, can anybody tell me what is the indication for urgent surgery in a patient who is having infective endocarditis? All patients do not need urgent surgery. Yes?
Severe MR, sir.
Okay.
Large vegetations more than 1.5 centimeters.
Okay. Always have a structure in your mind. Do not utter the words from here and there. Surgical indications, 4 conditions. Remember, heart failure, persistent infection, when you are suspecting that this patient will be having high risk for embolism, and if your patient is having prostatic valve endocarditis. Heart failure, the authors, this is the recently published article, authors recommend pursuing surgery within few days whenever acute severe left-sided valve regurgitation occurs. You have already told, MR. Regardless of the NOIHA class, when you are getting MR and patient is in failure, definitely patient needs urgent surgery. Persistent infection, both European Society as well as American Cardiology Society, they recommend surgery when you are getting highly resistant organism, evidence of abscess or penetrating lesion or persistent bacteremia. That's the reason why we send 3 sets of blood culture at the interval of 12 hours. All predictive of persistent infection with antibiotic therapy. So you have to definitely plan for surgery. Embolic risk reduction. Both European Society as well as American Society, they consider vegetation size as an indication to consider intervention with a goal of reducing the future embolic risk. But yes, the European Society have their own the parameter. The urgent surgery when you are getting aortic valve regurgitation, vegetation, or mitral valve vegetation more than 10 millimeter with severe stenosis or regurgitation, both can happen, regurgitation as well as stenosis more than 10, and low operative risk or any vegetation more than 15 millimeter. SCCHA guideline, they suggest that you should go for early surgery for left-sided mobile vegetations more than 10 millimeter without respect to lesion severity or operative risk. So you are getting left-sided mobile vegetation more than 10, go for early surgery. Now, prosthetic valve endocarditis, European Society of Cardiology, they recommend urgent or elective surgery for prosthetic valve endocarditis when you are getting heart failure, severe prosthesis dysfunction, abscess, or staphylococcal or non-HASEC gram-negative organism. So these are some of the indications. You have to just remember the headlines: heart failure, persistent infection, embolism, high risk of embolism, and prosthetic valve endocarditis. Am I clear? Now, question number 12. 79-year-old female presented to a general practitioner with chest discomfort and flu-like illness. Past history: hypertension, patient was on hydrochlorothiazide and captopril, and patient was also having vaginal thrush, and for that patient is on ketoconazole. She was also receiving digoxin 0.25 milligram daily. Patient is having allergic rhinitis and a flu-like illness, and patient started taking non-sedating antihistamine. Now, after that, the patient experienced a number of syncopal episodes and presented to the ER. Clinical examination: patient is having well perfused, normotensive, but when you did the regular ECG in the ER, burst of irregular pulse were present. So the clue here: 79-year female, chest discomfort, flu-like illness. Because of the flu-like illness and allergic rhinitis, patient was started taking antihistamine, and then the patient is having this irregular pulses. When you did the ECG, this is the ECG finding. What is happening?
She has non-sustained VTAC.
Any
I
answers?
I answered this question because ketoconazole can cause QT prolongation.
Yes. And also the non-sedating antihistaminics, they both can cause torsades de pointes. This is a favorite question from the European examiners. I have got this question in my EDIC too. And the treatment is straightforward: IV magnesium sulfate. Clear? Now, question number 13. 40 years male HR executive comes for routine investigation for insurance. You get the ECG like this. What is the ECG diagnosis? What is the treatment? Anyone?
First degree heart block, treatment conservative.
Okay. Anyone? Clue number 1. 40-year male, routine investigation for insurance. So they have given you the clue that patient is normal, and this is a normal finding. So when you are getting normal patient but abnormal ECG finding, any DD?
Extracardiac lead placement, which is abnormal.
Yeah, in this patient, it is a lead reversal. You can see the classical, the P wave, QRS, everything is negative in the lead 1, and nothing is required. Treatment is nothing. So reversal of LA and RA electrodes. What happens? Lead 1 becomes inverted. Everything would be negative. Lead 2 and 3 switch places, and you will get the leads AVL and AVR. So that would be switching the places. You can see AVR would be all positive. Lead 1 will be negative. Right? So lead 1 is completely inverted. P wave, QRS complex, and T wave. Lead AVR often becomes positive like this here. and there may be marked right axis deviation. And the treatment or the definitive diagnosis, you change the leads and you will get the correct ECG. This is just one of the treatment. If somebody will be asking, it is not the treatment, but what is the thing that you will do next? If the examiner would ask you, you would be just saying that I will change the leads and again check. But the DD with the lead reversal would be dextrocardia. Dextrocardia would be having the similar ECG finding like the lead reversal. But you can see here right axis deviation, positive QRS complexes in the AVR, lead 1 inversion of all complexes. So the dextrocardia is the physiologic, you can say the lead reversal or the normal lead reversal. And you can see AVR all positive and 1 all negative. This is the clue. AVR all positive, 1 all negative. And the differential diagnosis, just a formula I want to share with you. RAIN. RAIN is RA, right axis deviation. IN. I means lead 1 is negative. Clear? So RAIN. And you will get positive umbrella. That means positive AVR. AVR would be positive. Positive umbrella in RAIN. This is the clue. Positive umbrella in RAIN. And the umbrella is your AVR, positive. And there would not be having any R wave progression. So R cannot climb the stairs from V1 to V6. So these are some of the things that would be asked. Accidental lead reversal, specifically reversal of the left and right arm electrodes, may produce a similar picture to dextrocardia in the limb leads, but with normal appearance in the precordial leads. Clear? So positive umbrella in RAIN. Absent R wave progression in the precordial leads. Dextrocardia, lead 1 all negative, lead AVR all positive in the dextrocardia. This is the clue. Question number 14. 28 years male, known carcinoid syndrome, presented with vomiting, shortness of breath, tachycardia and palpitations. Multipara monitor revealed this one. Can anybody tell me the finding, some significant finding here? Finding intervention. Any abnormality you are getting in this monitor? In the ECG, in the IBP, in the CBP, in the SpO2, in the ETCO2, anything? Here, what is happening? The clue number 1, carcinoid syndrome. Yeah, the CBP is very high. You can see here, CBP 29. Can you see? And the waves here. Yes. Yes, yes. So the CBP A, C, V, X, Y and Y descent. You can see the C and V are fused here. This is a little bit difficult. We just deliberately kept it. Fusion of C and E wave suggestive of severe tricuspid regurgitation. So when the C and V waves are fused, it would say, or it would give you a clue towards the tricuspid regurgitation. Why the patient is having tricuspid regurgitation? Because the clue number 1 is here. Patient is having carcinoid syndrome. So there is release of hormones, and that would lead to the vasodilation, and that is causing the right-sided carcinoid in the heart, and the TR is there. So fusion of the C and V wave. And what is the intervention? You would send the patient for 2D echo and surgical review. Maybe the patient needs surgical correction. 70-year female, widowed, presented with syncopal attack in emergency. Patient is in cardiogenic shock. Troponin is positive. You send the patient for coronary angiography, normal coronaries. Provisional diagnosis and management. Tachycardiomyopathy, broken heart syndrome. And what is the management? Okay. Management of the shock with vasopressors plus minus inotropes. You have to rule out ischemic heart disease. Already you have done this with CAG. Heart failure management with the diuretics and afterload reduction. Clear? Tachycardiomyopathy, very favorite question. They may give you a clue with the subarachnoid hemorrhage management, and then the patient developed some of the ECG findings and the echo finding. It would be typical Takotsubo cardiomyopathy or stress cardiomyopathy. Clear? Question number 16. 66-year male smoker while driving car had head-on collision with a truck and sustained a blunt chest injury. Admitted to the emergency department with shock. And these are the echo findings. What is the differential diagnosis? Ventricular rupture, aortic dissection, pericardial effusion with tamponade. It could be when they are asking about differential diagnosis, you have to tell about at least 2 to 3. What is the treatment? If it is pericardial effusion with tamponade, definitely pericardial tapping, pericardiocentesis. And if the patient is having ventricular rupture or aortic dissection, definitely thoracotomy and repair. Question number 17. 70-year-old man presented with dizziness and near syncope. What is happening here? Always have a format when you are getting one ECG, how to look at the ECG. Then only you will find some of the abnormalities. I'm just giving you a clue because I know you are all tired after almost 3 hours of discussion. PP, PPP. What I am right now trying to show you.
Yeah, there is a dissociation between the atria and ventricle. But
this is AV block, 2nd degree, Mobich 1. And we all know if you are getting Mobich type 1, which is known as Wenke-Bach, is often not necessary. You have to wait and watch. You can try with atropine if your patient is having hypotension and bradycardia. If unresponsive to atropine, pacing, which could be due to by the transcutaneous or transvenous. And if the patient is on any beta blockers, calcium channel blockers or digoxin, definitely you have to reduce the dose or you have to stop the medication. But Mobich type 2 definitely is something we are concerned with. In that, you have to immediately send the patient for pacing. And in case you are not doing it, these patients would ultimately land up in the complete heart block. And these patients, Mobich type 2, they would not be responding to the atropine normally, like the Mobich type 1. So with this, we conclude this session of cardiology. And we have discussed about 2 important the CCS, as well as I tried to cover the CBS questions, taking questions from the hemodynamics, taking question from the ECG, taking question from the echo, which is relevant to the cardiology domain. And with this, we complete the first module, that is cardiology. Next, we'll be announcing the date for the cardiothoracic surgery. After that, this is the agenda for our TRICS 2. Neurology, sepsis, trauma, toxicology, respiratory, onco, pregnancy, burn, drowning, nephrology and endocrinology, gastroenterology, ethics, organ donation, communication, hemodynamic monitoring, and miscellaneous. In miscellaneous, we normally try to cover those topics which are not in a specific domain, like I would say some of the environmental exposures, some of the recommendations or suggestion from the trainees or attendees, they normally are like post in our groups. So we would be taking those in the last module. And after that, there would be 3 mock tests, which would be live, Zoom, just like in your real exam. So 1 examiner, 1 student, and they would be taking you through the whole CCS and CBS from the total critical care. So it would not be specific to the domain, rather any domain can be asked in the real exam. So this is the practice test, mock 1, mock 2 and mock 3. And in between, as suggested by few of our attendees, so we would be taking the after these 3 modules, we would be having 1 live class, something like that. So whatever questions, queries and some of the confusions the attendees would be having, we will be taking in those live classes and discuss and clarify. And then we would be having again finish the next 3 and we will have 1 live class, something like that. So thank you very much for joining us. And I know you are all tired and the heartbeats are, I think, right now increasing. So we would be stopping here and wish you all the best. And in case you need any help, we are there to help you. And we are happy to help all of you to sail through this difficult journey of EDIC Part 2. Thank you very much. Kindly share your feedback in the group, in the WhatsApp group, as well as here also. And if you want any of the things to be changed, modified, we are happy to change it for all of your benefit.